Dr. Githinji Gitahi has served as the Group CEO of Amref Health Africa since 2015, especially as you moved from clinical practice to leading major health organizations. What inspired that shift?
We were nine of us growing up. My mother had nine children, and number eight of them. Scarcity of food was obviously there. And therefore, the coffee farm, we were the labor for the coffee farm. You know, all my early life before I went to high school, that should have been about 15 years or so. I gained this experience and understanding.
Now, you have played key roles in global initiatives such as the Universal Health Coverage 2030 and the Partnership for Maternal, Newborn, and Child Health.
Well, the reason that I have been involved in the implementation of One Amref is because of our history. And these offices were created as Amref offices in US, Amref in Germany, Amref in Netherlands, and then the African countries also that were doing the programs also started to grow to the countries we are in now that you said are about 35.
Your leadership, commitment to universal health coverage, and passion for transforming Africa's health systems are truly inspiring. Dr. Githinji Gitahi has served as the Group CEO of Amref Health Africa since 2015, leading the largest Africa-based health and development organization, which delivers health services to over 11 million individuals annually across 35 countries. A trained medical doctor, Dr. Gitahi also holds an MBA in marketing from the United States International University and a certificate in strategic perspective for nonprofit management from Harvard University. Before joining Amref, he served as the Vice President and Regional Director for Africa at Smile Train International. A vocal advocate for universal health coverage, Dr. Gitahi co-chairs the Strategic Advocacy Committee for the Partnership for Maternal, Newborn, and Child Health. He serves on multiple influential boards, including the Coalition for Epidemic Preparedness Innovations and the Board of Trustees of the Safaricom Foundation. In 2023, he was appointed by the United Nations Secretary General to the Scaling Up Nutrition Movement Lead Group, focused on ending malnutrition by 2030. In recognition of his contributions to the health sector, he was honored with the Moran of the Order of the Burning Spear in 2018 by the President of Kenya. Welcome to this interview, Dr. Gitahi. It is an honor and a pleasure to have you with us today.
Thank you very much, Petro, and really good to connect.
Wonderful. Dr. Gitahi, how did growing up on a coffee farm in Nyeri, Kenya, shape your values and leadership, especially as you moved from clinical practice to leading major health organizations? What inspired that shift?
Well, I would like to first say that it was a small coffee farm. We were nine of us growing up. My mother had nine children, and number eight of them. Scarcity of food was obviously there, and therefore the coffee farm, we were the labor for the coffee farm. All my early life before I went to high school, that should have been about 15 years or so. I gained this experience and understanding that actually work is a moral thing. Work is a collective thing. That when you work, actually, you're working for others, not for yourselves generally. And therefore, the element of social justice, of doing work to help others, because we would then, after we finish picking the coffee on our farm, we'll go to the neighbors as well. So I would say that it's foundational for me, that it gave me a moral ethical framework of work, and it also introduced me to this concept of social justice.
Wonderful, a very inspiring story. Now, you have played key roles in global initiatives such as the Universal Health Coverage 2030 and the Partnership for Maternal, Newborn, and Child Health. How do these platforms shape and influence national health agendas across African countries?
It is a double-sided sword, Petro. What happens is that we know that health systems are national. We don't have anything called a global global health system. It doesn't exist. Health systems are national. They're national, they're shaped by their people, by their parliament, by their financing. But there are certain elements of that national health system that require global collaboration and global solidarity. If you're going to your universal health coverage plan in a national level, you can say that other countries are doing this. So that's global solidarity, and it gives legitimacy to what the governments are doing. It also enables civil society. When they are national, these global health declarations, it enables civil society to go back to their national health system and hold governments accountable. Now, as you go along, of course, in the global health initiative and the global health space, you have certain declarations that are legally binding, like the pandemic treaty. And therefore, involving ourselves in those is also necessary for organizations like PMNCH. They also bring in knowledge synthesis that helps countries and civil society, government and civil society to determine for what you need to do for the best interventions. So that's how the interlinkage is. But at the end of the day, if it's not happened at the national level, it's not happened anywhere.
Definitely. But thank you for sharing. Very insightful. Now, you have led Amref Health Africa since 2015 and introduced the One Amref approach. How has this philosophy shaped the organization's work, and what has been your most defining movement as CEO so far?
Well, the reason that I have been involved in the implementation of One Amref is because of our history. Our history, in short, is that Amref was started on African soil by its benefactors originally in 1957. And when the founder started Amref, over time, because there were, the people you're helping are not the same people who are going to donate for our work. So we needed to find people to donate for the work that we're doing in Africa. And through that, we created certain fundraising offices in Europe and North America, in high-income countries. And these offices were created as Amref offices in US, Amref in Germany, Amref in Netherlands, and then the African countries also that were doing the programs also started to grow to the countries we are in now that you said are about 35. But what happened because of that history is that each of these were seeing the Amref mission from their own lenses. And it was important for us to have a common drawing of our mission and a common drawing of the vision. And that also brought in a common approach to its implementation. And that was the One Amref agenda. Now, the most defining moment for me on this particular issue, because I have very many defining moments in Amref, including when I go to the field and I meet women whose lives have been changed, who had fistula, women whose girls who did not go and undergo female genital mutilation because of the Amref work. Those are my most defining moments. But on this One Amref journey is when we finally got together as an organization and I started hearing the language of everybody. And this common language is what to me reflected the One Amref approach, because it's not about the memo, it's not about the documents we write. It is the culture and how we do things around where we work.
Thank you. One language. Now, as we witness shifting geopolitical landscapes and a tightening donor environment, how do you see these dynamics influencing the future of health systems in Africa? Is Amref Health Africa adapting its strategies to navigate these changes? And are there any key lessons or models from Amref's work that could help the continent build a more resilient and self-reliant health future?
National health systems are run by national taxes and households, because the taxes are not enough. So households sell their land, their livestock to pay for bills, of course, in hospital, because their governments can't afford to pay for them. And the role of development assistance, as we see it, is to actually focus on particular areas that have a huge burden of disease, that are transformational, or that have a particular global agenda. This development assistance that we are discussing about the geopolitical shifts contributes approximately 20% of the national health finances, only 20%, and the rest is 80%. But this 20% is really critical, because even as President Kagame said one time during COVID, that because we do things ourselves doesn't mean we do them alone. So we still need development assistance. So what is Amref doing? For us, we believe that the best pathway to a healthy continent is promotion and prevention, is the creation of health, not the treatment of disease. Africa cannot afford health care. But Africa can afford health, but cannot afford healthcare. So if we wait for people to get sick to treat them, from the numbers I give you shortly, we can't afford it. But if we focus our money on creating health, and how do we create health? You engage communities and you make sure they're empowered. This is women and children and girls. Number two, you provide early diagnostic primary care, point of care support that is also led at community level, household level, that a woman who is pregnant doesn't need to go to a facility to get checked for antenatal fitness. She can be checked by a community health worker at home who has in her hand AI or technology for point of care that is necessary. Secondly, that we must involve multisectoral approaches, that people must have access to clean water and sanitation and nutrition. So we focus on that. So what is Amref doing? Amref is actually in the process of supporting governments a redesign of the primary healthcare system to ensure that even as development assistance reduces, the little money we have can go further and can do more to keep people healthy and avoid disease. That's the work we're involved in right now.
Thank you for sharing a very different approach than the traditional. And yes, finance is very important in health. Going back to the World Health Organization, in your video on the World Health Organization's New Pandemics Treaty highlighted at the 78th World Health Assembly, you mentioned the health systems we need in peacetime is the one we will need in wartime. How can government, civil society, and healthcare providers ensure readiness in both peace and crisis?
Indeed, the health system that's serving the people on a day-to-day is the one they will need in crisis or in wartime. And therefore, for you to build this health system, it has to be built, number one, to be people-centered. Number two, to be community-led. Those two terminologies may sound like jargon, but they are really critical. When you have a people-centered health system, it means that if you have people who have who live with disabilities, the health system is built for them because it's people-centered. Now, number two, it is that it's community-led. That these people that the health system is serving are the leaders of the health system. They are the ones who know when the health system needs to be rejigged. They're the ones who know whether the health system is responding to their day-to-day needs or not. And they're the ones, therefore, when the health system is attacked by, for example, a pandemic, the people know how to shift it, to adapt it to the situation. On top of that, you then build the support the community and the people need to run this responsive health system. You give them the necessary tools of information, and information might not be just the data we receive from the hospitals, must be information that is built from community hub. Secondly, you extend service delivery to be people-centered, meaning that if there is no facility, you have other forms that replace the facility where people can have health services. We have in the past used camels to deliver family planning commodities to people in pastoralist areas. Then you make sure that it has commodities, and the budget for commodities is governed at the community. We always say that facilities that are most effective are facilities that have the power of devolved resources, that they can actually manage and decide when to pay the water bill and the electricity bill and when to hire an extra nurse. And finally, that you allow this whole thing to be led at the community level with the health workforce and the communities themselves. That system must also have disease surveillance embedded in the community. That communities must know how to respond to events. They may not have the clinical know-how of what the event means, but they know that the event is unusual and they know how to respond to that unusual event and how to report it. That is community-based surveillance. Now, all these systems would then support crisis because they will be the foundation of response for crisis.
Thank you. A foundation, a keyword. Dr. Gitahii, thank you for sharing your inspiring insights and vision. Your leadership, commitment to universal health coverage, and passion for transforming Africa's health systems are truly inspiring. We are deeply grateful for your time and wisdom. It was a great pleasure to have you with us today. Thank you very much.
Thank you very much for having me. I'm honored. Thank you.